this is Sharon Terry from Genetic Alliance. Welcome to our webinar, Managing the Massive Measures, Real People's Real Data Made Useful. Our webinar today will be about PROMIS, and our presenters will be San Keller, who's from the American Institutes for Research, and Nan Rothrock from Northwestern University. Before we begin, just a couple housekeeping details. All of our webinars are recorded and archived. That means you can see both the recording, listen to it, and also get the slides. The sessions usually last somewhere around a half an hour of presentation and a half an hour of questions and answers. We try to get to all the questions. Instead of having the 100 or so of you that are on the line ask questions, we'll ask you to type them into the dialog box that's on the usually right-hand side of your screen. It's called Go to Webinar Control Panel. There's a drop-down area that says questions. You can type your question there. You can type it any time during the presentation, and we will get to answering those. We try to group them, so if you don't have exactly your question asked, we hope that we've put it in the right kind of grouping for our presenters so that they're not kind of going back and forth between different kinds of questions. So again, welcome to everyone who have just rolled into the webinar. We still have a couple people. We opened up the waiting room, so to speak, just a moment ago, and we're still having people roll in. These webinars are recorded, and the slides are available sometime around a week after they are presented. This is part of a series called Managing the Massive Measures, and you can see the other parts of the series on our website in our archive, and you can also look at the upcoming ones, which I'll talk about at the end of the webinar. So without further ado, I'm going to turn over this PROMIS webinar to San and Nan. Thank you.
Thank you for that introduction. This is San Keller. I am the principal investigator on one of the coordinating center grants for the PROMIS initiative. So PROMIS stands for Patient-Reported Outcome Measurement Information System, and this initiative started about 10 years ago, and it was a program across NIH initiative, across institutes and centers to provide a technology that would support the clinical research enterprise. And in this presentation, I'm going to back up before PROMIS and talk a bit about patient-reported outcomes, why they are important, and describe how PROMIS grew out of that, and then a little bit about how the measures are developed and tested, and then how you can find out more information about the measures, which will segue into Nan's part of the presentation, which will be about how to access and use the measures. So, there are many patient outcome measures, but not all of them are patient-reported. Some of them are performance measures, such as the 6-minute walk test. Some are observer ratings. The FIMS is an example, or the Glasgow Coma Index, and then some are patient reports. And a very familiar patient-reported measure is the how would you rate your pain on a scale of 0 to 10. So why are patient-reported measures important as opposed to all the other medical information and health information we have? Well, some of that health information is quite crude and doesn't move with intervention. So, for example, survival, it's a 0-1 measure, and you can't, it's difficult to measure improvement from, healthy to dead. There has, up until about 15 years ago, a lot of the quality measures of healthcare were how often something was done and to whom. And when you measure quality in terms of procedures, what's done, then there's no limit to how much you should do. And this is the difficulty with this happens when you're when they're skyrocketing healthcare costs. And so a focus on what you get for that investment of healthcare has become important. So a focus on outcomes. But some health outcome data is impossible to get by any way other than asking patients. There is no direct other measure of pain. The measure of pain, for example, the direct measure is asking a person about their pain, and there are other examples. Fatigue. It's very difficult. You can infer fatigue by some clinical markers, hemoglobin and so on, but they don't correspond one-to-one to a person's experience of whether or not they're fatigued. And there is some health information that's not practical to collect any other way. So, for example, medical history is often a patient report over and over again with every new provider. And some health information can be collected other ways, but it's very burdensome. So, for example, how someone is functioning at work. But that would require following someone around, having multiple raters, and so on, and it's just not practical. So what are patient-reported outcomes? Well, they ask about activities of daily living, and PROMIS does this as well. How well people can think and remember, how much they can participate in different physical activities, including chores around the house and recreational, and then how well they're able to fulfill societal roles such as parenting, as a worker, as a family member, and so on. And then the emotional well-being, how much anxiety, depression, and so on people have. And this is an example of a single item measure. This is a screen for if you take PROMIS on the web, the computerized version, you would see something like this. So this is a pain behavior question. So why are patient-reported outcomes necessary? Why not just have the provider rate how the patient is doing or ask the caregiver? This is an example. This is a very old study. It was a study of outcomes for anti-hypertension drugs, and people were asked about changes in quality of life with taking the drugs. And so you can see that different responders had very different impressions. So nearly 100% of physicians reported that the patient's quality of life had gotten better, whereas about 50% of spouses said the quality of life had gotten worse. Almost 100% of spouses, said the quality of life had gotten worse, and about 50% of patients said that it had gotten better. So if you want to know what is the experience of the patient in terms of their functioning and well-being, you really need to ask the patient. So are these measures valid and reliable? Do they provide information that is useful? These are actual data from the medical outcome study, which was a 5-year longitudinal study of people with chronic disease. They took a 136-item survey at baseline, and then every year thereafter for 5 years. And this is a prediction of job loss within 1 year according to their baseline measure, and this is a measure of physical functioning. So, for example, those who were 1.5 standard deviations below normal on the physical function measure, 30% of those were out of work a year later. This is, again, a measure of self-reported health, and it shows the prediction of the percent of people from the medical outcome study who would be dead in 5 years based on their responses to the measure at baseline. So I'm often asked, well, when do you use these measures? What's a good application? And my answer is, when do you want to know about health? When do you want to measure health? And so patient-reported outcome measures can be used in any situation in which you would want to measure health. So in clinical trials, comparative effectiveness research, quality improvement to measure outcomes, personalized care, and then at a population level. So if these measures are so useful and practical and patient-centric, why aren't they used more often? Much of the barrier to the use of these measures can be traced back to standardization. And what do I mean by that? Well, this is an example. So you have two different metrics, Celsius and Fahrenheit, each get with a number of 32, very different implications. So 32 on Celsius is quite warm. 32 in Fahrenheit, you might want to start wearing a jacket, and some people might be very cold at that. People from the south might be very cold at that temperature. And here's a dramatic example of the problem of lack of standardization using actual data from a general population sample. These are two different patient-reported outcomes, both measuring fatigue energy. One is on the right side is the Nottingham Health Profile. On the left side is the SF-36 Vitality Scale. And so each one paints a very different picture about the amount, whether or not fatigue is a problem in this population. If you were using the Nottingham Health Profile, you might conclude that the majority of people are not tired, they have no problem. If you're using the SF-36, on the other hand, you might conclude that there are some people who are functioning very well, but there is some lack of energy in the rest of the population. So the lack of standardization has really been a barrier to the use of these measures. This is another example. These are measures of prostate cancer quality of life. And as you can see from this table, there are different numbers of questions, different domains that are asked, different recall periods. Basically, the development of PROS started back in the 60s, and it has proceeded organically with people developing their own patient-reported outcomes for a particular application. And so there's a proliferation of these measures, each providing a different metric, and that has been a major problem. And these are just 4 of the most widely used measures of quality of life in this particular condition of you know, tens of probably more than 20 measures. So how did this happen? Well, you have different populations at different level of the trait. So for example, for fatigue, you would have someone bedridden versus someone who is functioning normally. So the easiest way to standardize assessment of patient-reported outcomes until this point has been to ask the same questions of everyone. Well, you might need 90 different questions in order to measure the fatigue of someone in the nursing home and someone who's an Olympic athlete on the same metric using the same scales. It's just not practical. So people develop fixed forms for different types of populations. And I'm going to speed up here because I'm over my time. And so to the rescue, I believe, having been working in this field for 20 years, came the NIH. What was needed was a national effort, coordinated effort toward a standardization of measurement for each of these domains of health, and this is part of the Common Fund, with multiple institutes contributing to PROMIS. The PROMIS 2 has 12. We also brought in another one from PROMIS 1, 13 primary research sites and 3 coordinating centers, and we're in the last years of that effort. And created have been, at this point in the presentation, usually I had put up a domain framework map, which actually Nan and colleagues had created, which was incredibly intricate and detailed, and it's actually no longer appropriate. And so we can't put on one slide all the different measures of PROMIS, all the different item banks, and so on. So suffice to say that there are adult and pediatric, and that they fall into physical, mental, and social health, and I'll show you how to find out more information. PROMIS was constructed from item banks, which feed into adaptive computer assessments or fixed forms, paper and pencil forms. And it involved over 10,000 respondents, and also some clinical respondents, the general population, and some chronically ill respondents, to develop this calibrated item banks. And the calibrations are determined on the basis of probabilistic modeling, which places an item on a continuum. So, for example, item 1, are you able to eat, might be at the very low end of the continuum of physical functioning, might apply to someone who's in bed. Whereas item 7, are you able to run 5 miles, would be at the high end of physical functioning and apply to someone who might be training for a marathon. And so using the statistical modeling technique, item response theory, these items and their responses are placed on an underlying continuum. And what this enables is a computer, and I'll go back, to select an item that's appropriate for each respondent, a set of items, and calculate a score on that continuum that's precise without having to ask them all the questions. Beginning, one way to begin is to give a person a question that 50% of respondents would endorse, and then depending on the response, give them either, for example, physical functioning. If they say they can walk a mile, then you might ask them if they can walk 2 miles, but you wouldn't ask them whether they can walk 2 or 3 blocks. And with each question, the amount of error around the score decreases until a particular standard that's used to stop the assessment. So it could be an error of 0.3, it could be a length of 4 questions, and so on. Precise measurement that's low burden with PROMIS can either be provided with the short forms or with computer adaptive assessments. But this shows you the benefit of computer adaptive. So that on this graph, lower is better because the vertical axis is the amount of error, and the horizontal axis is where on the continuum of fatigue people are. The lower line shows what the amount of error you would have if you ask the person every item in the bank, which there are now 92. And then the brown line shows what the amount of error you would have if you had a 13-question computer adaptive assessment. That's the next most precise. The pink line shows you the amount of error you'd have if you had a fixed form that was 13, and so on. So you can see that it's a relationship between the number of items and how they're administered. And this assessment places people on a continuum. So PROMIS is scored so that the average score in the general population is 50. We can immediately see that this person is one standard deviation below average. And these are interpretations associated with that. So to learn more about the items, you can go to www.nihpromis.org. You can click on the Measures tab, click on Domain Frameworks. It'll bring this up. You can click on, for example, physical functioning. It'll bring you to this page where there are multiple subdomains. If you're interested in fatigue, you can click on fatigue. It'll bring you to this page where you can see the empirical research behind the fatigue item bank. If you go back and you click on Learn More, it'll bring you to Assessment Center, www.assessmentcenter.net, and the manual for the fatigue item bank, where you can really drill down and all the measures of fatigue. And this is a good segue to Nan's presentation about how to access the measures and use them from Assessment Center.
Thanks, Ann. Thanks for inviting me to present today on accessing and using PROMIS instruments. Let's first talk about access. So if you're interested in taking a look at the instruments to see what kinds of items are included, the best way to do that is to go to assessmentcenter.net, that website that San just mentioned, and click on this button, Request PDFs of PROMIS short forms. You'll be able to download PDF print-ready versions and review those to see if it works for your purpose. Right now, there's a selected set of short forms included in that download, and that's being expanded to include all PROMIS short forms and the full item banks in English and Spanish, and that will be available sometime this summer, so you can check back for updates. In terms of using PROMIS instruments, there are a number of online data collection tools that have PROMIS instruments embedded in their systems, and I'm going to talk about a few of these next. The short form PDFs that you downloaded from the website can be used. You can photocopy them and administer them on paper. And it would require a scoring manual in order to make sense of people's responses. You can access the scoring manuals on the Assessment Center homepage on the scoring manual link, and in those manuals are conversion tables that give you instructions on how to convert a summed raw score to the standard T-score, which San mentioned has a mean of 50 in the U.S. general population, standard deviation of 10. There's also some information about how the instrument performs, such as this test information plot we're looking at here, showing the range of the particular trait that's being measured well. If you want to use online data collection, there are a number of tools available for that, and we're real proponents of exploring this as an option for a wide range of issues that I've listed here. It enables a number of features, including scoring, allowing a participant to select their language, having automated backup of all data, and also, most importantly for PROMIS, okay, excuse me, I keep getting this pop-up. For PROMIS, it allows you to administer computer adaptive tests or take advantage of this item response theory scoring. So the first tool that enables PROMIS instruments is Assessment Center. This is a web-based data collection tool. You establish your own study-specific URL where you can direct participants to go and complete instruments. The library includes all PROMIS measures as well as other measures from NIH-funded measurement initiatives, including NeuroQual and the NIH Toolbox. Lots of research features are enabled, including single time point or multiple time point studies, multiple study arms, randomization. There's some tracking of accrual. All data is scored and available in real time for export. And you can administer PROMIS instruments in multiple languages. If you want to learn more about Assessment Center, you can go to the Assessment Center homepage listed here. On that homepage, you can get access to a really long, detailed user manual. There are video tutorials explaining how to use the site. Within the application is a help tool, and then we also have a help desk. REDCap is another data collection option. This is also a web-based platform intended for research. It includes lots of features that are really helpful, not only for survey types of studies, but also lots of tools that help with study management. So audit trails, automated exports, having a calendar or scheduling tools. It's available in English and in Chinese and has a huge number of partners. Right now, selected PROMIS short forms are included in the REDCap library. By this fall, we will have all PROMIS short forms as well as computer adaptive tests included in the REDCap library. There's no cost to REDCap for consortium partners, and if you want to learn more, you can go to the REDCap website listed here. EPIC is another platform that includes PROMIS instruments. EPIC is an electronic health record system, and it has a patient portal where you can embed patient-reported outcome instruments. Availability of PROMIS depends on what version of EPIC you have. Right now, selected short forms with raw scoring, so using those lookup tables we saw a little earlier. That's an included feature in EPIC 2012, so if your site has EPIC 2012, you have this feature. EPIC is expanding what instruments are available, and in the fall there will be a much larger set of PROMIS instruments with CATs coming soon after. One of the advantages of EPIC is the instruments are scored in real time and are pushed back into the EMR, so you can pull out health data and PRO data. If you want to learn more, you can contact EPIC and get directed to the MyChart team. Another tool for using PROMIS instruments is the Assessment Center API. An API is an application programming interface. And basically what this does is it allows other systems to get access to the Assessment Center instrument library, which includes all of PROMIS instruments. And this is really the best choice if you already have a data collection system in place and you just want to pull in PROMIS without having to invest in a developer coding, CAT scoring, and administration algorithms. It does require a local IT person, and so that's something to keep in mind. So this is a schematic of how the API works. Starting on the right, there is an Assessment Center library that's hosted by Northwestern. And that library can be accessed by this API whenever desired. And then that API can feed into a local institution's survey software administration, keeping all results at that site. It's not pushed back to Assessment Center. The costs for the API are a flat fee for per server installation, and this is the way that REDCap is accessing PROMIS CATs. Other users include Saskin and the Madigan Army Medical Center, as well as many others in development. If you want to learn more about the API and whether or not it's a good solution for you, you can contact help@assessmentcenter.net. Bright Outcome is just one example of what is really proliferation in symptom monitoring softwares. Bright Outcome is focused on chronic conditions and really focused on collecting data via handheld device or smartphone. It includes PROMIS instruments in their own library. What it allows is for a patient to report on their symptoms, so their fatigue, their depressive symptoms, for example. And the Bright Outcomes software will create a history, can link a patient with educational information selected by the clinician or researcher. So for example, if your fatigue is over a specific level, you can be directed to resources for fatigue management skills. You can also alert a care team to contact a patient if a score reaches a certain threshold. And there's also a treatment tracker feature that allows clinical treatment information to be combined with this patient-reported outcome data. If you want to learn more about Bright Outcome, you can contact Dersheng Yang at Bright Outcome or go to their website. And then finally, the Assessment Center iPad app is in development. This is a true app in which it lives on an individual person's device, and they can complete a PROMIS instrument when offline. It has scoring, reporting, data aggregation, and data export features, but not that study management tool that is part of the larger Assessment Center. This is in development now and should be available in 2015. There are some costs, including a download fee and an upgrade cost. And again, if you want to learn more information about this, you can contact our help desk at help@assessmentcenter.net. So those are all of the ways you can access and use PROMIS instruments. Thank you for your time, and I think we're ready to answer questions.
Super. Thanks very much, San and Nan. That was really terrific overview. We have a few questions coming in, and actually some kudos as well. To remind the participants, we can't unmute you. There are too many of you, nearly 90. So we're asking you to type your questions into the question box that you'll find on the right-hand side of your screen in the GoToWebinar control panel. So we're going to begin with a question that we got early on in the presentation. A question asking, can PROMIS be used with patients with intellectual disability? What are the challenges associated with low cognition and perhaps some of the mental health conditions?
That's a good question. So, San, do you want me to tackle that? Or? Okay.
I would just say it depends on how much mental disability. There are a lot of populations that people believe cannot self-report or probably couldn't, who can. So, for example, children down to the age of 8 and with some assessments even down to the age of 5. People with schizophrenia, there's research supporting their ability to self-report. So I would say that it depends on how disabled. And Nan, do you have more details?
Yeah, I would agree with that. I would also add that PROMIS instruments were developed to try to keep the literacy demands as low as possible. So we were trying to target a 6th grade reading level or below. There's some domains where that's a little harder to do, but that was intended to try to ensure that the most possible people could self-report. The other thing that we've seen quite often with computer-based data collection is to have audio component where the items are read out loud. So if somebody does have difficulty reading or some kind of impairment where literacy would be an issue, having the item read aloud would still enable a self-report. But I do agree with Sam that there is a limit to kind of level of cognitive impairment that would be appropriate for any self-report measure, not just PROMIS.
Great. And a follow-up to that, and I think you started to answer that question as well, there's some interest in people with low vision or no vision accessing the measures in a computer-aided environment, which is, the technologies exist. How does PROMIS mash up with the technologies that currently exist, either low vision software or reading software?
So Assessment Center was designed to be compatible with screen readers, so individuals who are already using screen reading technologies should be able to use Assessment Center. Another project that our group has been involved with is the Talking Touchscreen, which is a derivative of Assessment Center that includes that audio portion, enabling a participant to click on a button and have the item read out loud. That's not a default in Assessment Center, but it's something that we can enable for a given study if needed. I think that is one of the advantages of computer-based technology, is that it enables a participant to be more independent in completing a self-administered instrument through using that, those adaptive tools.
And I would only add that we do get questions about whether or not PROMIS included people with disabilities in its development, and there was a site that was one of their specific focuses, was to look at that and to do research on that.
Great, thanks. Next question, can these instruments be used for young children ages 5 to 16? And so I think the invitation there is for you guys to talk about the PEDS and the proxy instruments at the same time, if you don't mind.
Sure. So the pediatric instruments are intended for self-report, as San said, down to age 8. There are parent proxy instruments that were developed for parents or caregivers to report on children as young as 5. Those two, as you know, a self-report and a proxy report don't correlate 100%, and so there are issues if you're trying to include participants as young as 5 through 16. You may need to make decisions about whether utilizing entirely proxy reports or self-reports, and then being aware of the not complete correlation between those two. San, would you add anything?
Oh, sorry.
No, that's a good explanation, and just taking that and extending it to being able to link the adult with the child. There's often people often ask, you know, can I want to include 16, 17, or 18-year-olds in a study of adult health, and there are now some ongoing research to link the adult measures with the pediatric measures. In the meantime, the PI from the pediatric site in PROMIS 1 advised that when he's using these measures and wants to include the older children, that he feels comfortable using the adult, but that isn't there isn't an evidence base behind that yet. So that's a little off the question, but
right, but important. And just to sort of finish the proxy question, are the proxy instruments only for children, or can caregivers also be administered a proxy instrument? If, for example, either you know, cancer at end stage, Parkinson's, right, Alzheimer's.
Right, this is a great question, and I hope somebody's taking notes on an RO1 idea. PROMIS didn't develop any instruments for adult proxy report. There have been a couple folks who are exploring how the self-report instruments work as a proxy measure, but it wasn't something that was funded by the PROMIS initiative, and it is an area where more research is needed, I think.
Great, thanks. In terms of self-report, can PROMIS eventually be integrated with wearable monitors or commercial personal health apps like Fitbit, for example?
It
sure.
Sounds like it could.
Yeah, I mean, any technology that's collecting that type of data that has a way of capturing a self-report from the person wearing it could embed PROMIS instruments in there. Bright Outcome is one example that's been doing that. So they're using some of the technology within a smartphone, but there are many for-profit vendors who are looking at ways of doing that.
Terrific. Has PROMIS been validated for use to document change? For example, pre-intervention to midpoint and then to post-intervention?
Okay, go ahead.
Go ahead.
Well, I was just going to say that during PROMIS 1, there was the development of the item banks, and then the next question was, well, can this measure change over time? So there's a special issue of the Journal of Clinical Epidemiology, and NAN is on many of those publications reporting out that research. And PROMIS measures are being used now in longitudinal studies, and there are publications documenting that. And Nan, can you describe some specific ones? I don't know more offhand.
Yeah, the ones I'm most familiar with are the ones you mentioned that were funded by the PROMIS 1 initiative. And so those are looking at longitudinal assessment, pre-post intervention in COPD following treatment for symptom exacerbation, in heart failure following heart transplant, in lower back pain following steroid injections, arthritis, and depression or depressive disorder following initiation of a new depressive treatment. So more information about those studies is on the PROMIS website, nehpromis.org. But as San said, these measures are being validated by many people outside of the PROMIS network, and the best place to find out if your specific domain of interest has validation data in your population of interest would be to go to the PROMIS website and search on the publication by domain page to see what pubs are available.
Great. Is there, while we're on web sites, is there a web location to see what will be different in PROMIS 2?
Go ahead. I don't understand the question, actually.
I think go ahead.
Yeah.
PROMIS 2 was funded to do two things: to develop new item banks that weren't developed, so content areas that weren't developed in PROMIS 1, and also to extend validation data. So the new instruments that are being developed are going to be made available in the next year or so, depending on the individual group's timeline. When those become available, we embed them in the library, we post information on the PROMIS website, on the Assessment Center website, we tweet about it, we include it in the newsletter, so all kinds of ways to disseminate information about those new banks. In terms of validation studies, those are typically in a traditional, published in journals, and then information about that study will be shared via the website and those other outreach initiatives. So in terms of what is different, nothing that was developed in PROMIS 1 was necessarily altered. It's the expansion of the work that was done in PROMIS 1.
Super. And this is going to be our last question, so if other people have questions, the queue is empty and you can put in a question. I'm going to ask you guys this question from your point of view, and then I'll also answer this question as a PCORI executive committee member and funded entity. Is PROMIS working with PCORI and collaborating with PCORnet?
Dan, I'm going to give that one to you.
Well, okay. And the short answer is yes. We have steering committee meetings, face-to-face steering committee meetings for 3 or 4 a year, and I believe a couple years ago we invited PCORI to those meetings, and the head of the NIH went to PCORI to speak with the head of PCORI about PROMIS, and there was a request for proposals specifically related to PROMIS and expanding the research on PROMIS that came out last spring, and there will be another set of requests for proposals related to PROMIS research. And I know of a number of PROMIS investigators who are funded through PCORI and have built PROMIS measures into their research, and some that are on the PCORnet. I believe Chris Forrest. I don't know if there are others. Nan, do you have something to add?
No, I think that's a good summary.
Okay.
Great. And then I'll just add, as a PCORnet funded patient-powered research network, and also on the executive and steering committees, that certainly PROMIS has been prominent in our conversations about how across the network of networks we can standardize how we're asking questions and what kind of data we're collecting. We are a small group of us. The nice thing about PCORnet is it is a network of networks, and so each of these networks can choose to work with other ones, and there's been a group of us working with each other to see what, in fact, we would integrate into our research across many networks, so that we were, in fact, collecting data in a standardized way across the network. So PROMIS obviously offers, and I think the attendees certainly could see this, offers a really robust way to enter validated questions, et cetera, into a research protocol and not have to go through the process of validating them first. And in short timelines like PCORnet, we're at 14 months, I think, left. We really appreciate such instruments. Another question, are you aware of PROMIS being used in clinical practice to document functional limitation requirements for Medicare?
So PROMIS was initially funded as a clinical research effort, and what has happened over the 10 years of funding is we've seen an explosion of use in interest and actual use of PROMIS in clinical practice. That includes a number of hospital systems embedding PROMIS as part of their assessment of patients. So the Cleveland Clinic, there's a group at Stanford, there's a group with the Madigan Medical Center we showed earlier. A number of those are using PROMIS instruments as part of routine care to monitor important dimensions of self-reported health. Another aspect that's been happening is an interest in using patient-reported outcome measures as performance measures, and PROMIS has been working with CMS. CMS is exploring utilization or recommendations of using PROMIS as performance measures in various clinical populations. Sam, do you have anything else to add on the clinical use of PROMIS?
Just with that the last comment with CMS, we've also been in dialogue with the National Quality Forum, and so a couple years ago there was a series of workshops on patient-reported outcome measures, and PROMIS was featured prominently in those workshops, and the focus of the National Quality Forum is on performance measurement.
Super. Is there a pediatric version of the 10-question global health scale for adults?
It's in development right now and should be available in the next few months. We actually had a meeting last week where it was a subject of discussion, so that will be coming.
Great. Any other questions from our audience? I'll give you about 10 seconds, 20 seconds to type it in. Okay, I think we've answered everyone's questions. I want to thank you both, Nan and San, for giving us such a great overview. As I said at the beginning of the recording, this is recorded, the slides will be available, and this whole webinar is available on our archive site. Our next webinar coming up in this series, which is called Managing the Mass of Measures, Real People's Real Data, is on CDISC. And the date for that, Tuesday, July 1st at noon Eastern Time. And Becky Cush, Bron Kistler, and Rhonda Fassel will be presenting that day. So again, I want to thank our presenters. I know that all of our presenters, and particularly Nan and San, are open to questions beyond the webinar. You certainly can either send questions to us and we'll get them to them, or you can find them pretty easily. So again, we want to thank you all for attending and thank our presenters.
Thank you for inviting us.
Thank you.
Have a good day.
Okay, bye-bye.
Thanks. Bye-bye.